Welcome to Roadmap to Residency, Evidence-Based Applications. We are starting our pathology modules, and this is the first video. Now, every normal cell, okay, nearly each and every normal cell under influence of chronic inflammation or chronic injury can undergo some of the changes. It can go under atrophy, it can go under dysplasia, metaplasia, hypertrophy, hyperplasia. In this video, we will be mainly focusing on atrophy, hyperplasia, and hypertrophy. So, talking about hypertrophy, which is an increase in the cell size causing an increase in the organ size and weight. Hypertrophy in muscle tissue is caused by increased workload. Left ventricular hypertrophy occurs in response to an increase in afterload or preload. In ventricular hypertrophy, the changes in wall stress produce changes in gene expression leading to the duplication of sarcomeres, causing the muscles to be thicker or longer. In addition, there is an increase in cytoplasm, number of cytoplasmic organelles, and DNA content in each hypertrophied cell. Skeletal muscle hypertrophy occurs in response to weight training. Surgical removal of one kidney produces compensatory hypertrophy of the remaining kidney. Cell enlargement occurs in cytomegalovirus infections, and cytomegalovirus occurs because the virus increases the uptake of iron into the cytoplasm, which increases the growth of the cell. Now, each and every point mentioned in this slide is very, very important and may be directly or indirectly asked in your examination. Now, talking about hyperplasia, which is an increase in the number of normal cells. The causes include number A, increased hormone stimulation. So endometrial gland hyperplasia, which is caused by an increase in the estrogen, increased risk of developing endometrial cancer. Benign prostatic hyperplasia, which is caused by an increase in sensitivity to dihydrotestosterone. Unlike endometrial gland hyperplasia, there is no increased risk of developing cancer. BPH is frequently complicated by obstructive uropathy with thickening of the bladder wall by smooth muscle, which exhibits both hyperplasia and hypertrophy. This last point about BPH is typically very, very important. Chronic irritation. So the constant scratching of itchy skin can produce thickening, that is the hyperplasia of the epidermis. Bronchial mucous gland hyperplasia is common in smokers and asthmatics. Regenerative nodules in cirrhosis of the liver may occur in response to alcohol excess. Chemical imbalance. Hypocalcemia, which can lead to decreased serum calcium, stimulates the parathyroid gland hyperplasia, secondary hyperparathyroidism to bring serum calcium levels back toward the normal range. Iron deficiency produces thyroid enlargement, which is also called as goiter, as the gland works harder to increase the thyroid hormone synthesis. Now, both hypertrophy and hyperplasia are operative in producing goiters. Remember this line too. Stimulating antibodies. For example, hyperthyroidism in Graves' disease is due to thyroid stimulating antibodies, IgG, directed against thyroid hormone receptors, which cause the gland to synthesize excess thyroid hormone. Number E, we have the viral infections. For example, the skin infection with the human papillomavirus, HPV, produces epidermal hyperplasia or the common wart. Viral genes produce growth factors causing epidermal hyperplasia. Now let's talk about the mechanisms of hyperplasia. Hyperplasia depends on the regenerative capacity of different cell types. Number one, we have the labile cells or stem cells. Now, the labile cells divide continuously. Stem cells are located in the bone marrow, crypts of Leverkusen and the basal cell layer of the epidermis. Labile cells may undergo hyperplasia as an adaptation to cell injury. Stable cells, also called as the resting cells. So these stable cells divide infrequently because they are normally in the resting phase of the cell cycle. For example, hepatocytes, astrocytes, and smooth muscle cells. Now, stable cells must be stimulated, example, with growth factors, hormones, or absence of tissue to enter the cell cycle. Now, depending on the cell type, stable cells may undergo hyperplasia or hypertrophy as an adaptation to cell injury or both. Permanent cells are also called as non-replicating cells. So the permanent cells are highly specialized cells that cannot replicate. Examples include neurons and skeletal and cardiac muscle cells. Of the permanent cells, only skeletal and cardiac muscle undergo hypertrophy, not hyperplasia, as an adaptation to injury. Increased risk of progression into cancer in some types of hyperplasia. Endometrial hyperplasia may progress into cancer, and regenerative nodules and cirrhosis may progress into cancer, leading to hepatocellular carcinoma. Now let's talk about atrophy. Now, atrophy refers to a decrease in the size, number of cells, and weight of a tissue or organ. An interesting feature of atrophy that directly affects the patient's survival is its propensity to be greater in non-essential tissues, such as adipose tissue, than in higher functional tissues, such as that found in the brain. So the causes may include decreased hormone stimulation, example, hypopituitarism, causing atrophy of target organs, such as thyroid and adrenal cortex. Decreased innervation, example, skeletal muscle atrophy following loss of lower motor neurons in amyotrophic lateral sclerosis. Decreased blood flow, example, cerebral atrophy due to reduction in blood flow associated with atherosclerosis of the carotid artery. Decreased nutrients, example, total calorie deprivation in marasmus. Increased luminal pressure. So atrophy of the renal cortex and medulla in hydronephrosis, increased luminal pressure of the backed up urine compresses the vessels in the cortex and medulla, leading to atrophy. Thick pancreatic duct secretions in the CF include the duct lumens, causing increased luminal back pressure and compression atrophy of the exocrine gland. CF means cystic fibrosis. So atrophy of exocrine glands in the pancreas causes malabsorption of proteins and fats. Eventually, the entire pancreas is damaged, including the islet cells, leading to type 1 diabetes mellitus. Loss of cells by apoptosis, which is also called as programmed cell death. Now, there are some cellular and metabolic changes leading to atrophy. So first of all, we have the shrinkage of the cells, which is related to the increased catabolism of cell organelles, example mitochondria, and reduction in the cytoplasm. Organelles and cytoplasm form autophasic vacuoles. Now, what is autophagy or autophasic vacuoles? So autophagy is a catabolic pathway that is used to degrade or recycle cellular components controlled by a group of genes that control each of the steps of autophagy. Dysregulation of autophagy contributes to the process of aging, liver disease, cancer, and inflammation. Now, autophagic vacuoles fuse with the primary lysosomes for enzymatic degradation. The undigested lipids derived from the lipid peroxidation in primary lysosome are stored as these bodies, okay? Now, the polymers of undigested lipids plus protein are called as lipofuscin, sometimes called wear and tear pigment. Now, the excessive accumulation of lipofuscin pigment imparts a brown color to the tissue. In the setting of atrophy, it is called as brown atrophy, which is commonly seen in elderly population and is considered as a normal age-related findings. The protein synthesis is decreased, and protein degradation is increased, and increased protein degradation is handled by the ubiquitin proteasome pathway. Now, this is all about apoptosis, right? Now, this is the first part of apoptosis, and then we will be discussing about necrosis too. Now, apoptosis is also called as the ATP-dependent programmed cell death. The intrinsic, extrinsic, and or perforin or granzyme B pathways are present there. We'll be discussing all of them in the yellow slides. But this all intrinsic, extrinsic, and the granzyme B pathways, they all activate the caspases. Now, these caspases are the cytosolic proteases, which will cause the cellular breakdown, including cell shrinkage, chromatin condensation, membrane blebbing, and formation of apoptotic bodies, which are then phagocytosed. It is characterized by deeply eosinophilic cytoplasm and basophilic nucleus, pycnosis, and karyorrhexis. These terms are not so generally asked in the examination. But the cell membrane typically remains intact without significant inflammation, unlike necrosis. Now, this differentiating point is very important and will be asked in the examination. DNA laddering is a sensitive indicator of apoptosis. Talking about intrinsic or mitochondrial pathway, which is involved in the tissue remodeling in embryogenesis, occurs when a regulating factor is withdrawn from a proliferating cell population, which will cause the apoptosis of proliferating effector cell. It can also occur after exposure to injurious stimuli like radiation and toxins. Now, the important is the bags and back form. Now, these bags and back form pores in the mitochondrial membrane, which causes the release of cytochrome C from the inner mitochondrial membrane into the cytoplasm. And this cytochrome C will activate the caspases. And you know what happens when there is activation of caspases? There is a series of events leading to cell death. Now, this is what is called as a programmed cell death or apoptosis. Talking about extrinsic or death receptor pathway is when the ligand receptor interactions. For example, the FAS ligand binds to the FAS or TNF alpha binding to the receptor. Then the FAS and FAS ligand interaction is necessary in thymic medullary negative selection. And for example, important condition is the autoimmune lymphoproliferative syndrome, which is caused by the defective FAS-FAS-L interaction. So when there is no FAS-FAS-L interaction, there will be no apoptosis, so there will be lymphoproliferative disorders. Now, talking about the granzyme B pathways, where there is the release of granules containing porphyrin and granzyme B by the immune cells, and these porphyrin forms spore for the granzyme B to enter the target cell, which will cause apoptosis. Now, let's now talk about the necrosis. Necrosis is a very important topic, so we will take some time. So, necrosis, whenever there is exogenous injury, there is plasma membrane damage. And you know that when there is plasma membrane damage, the cell undergoes enzymatic degradation and protein denaturation. And then the intracellular components leak. Now, when these intracellular components leak, then there is a local inflammatory reaction. Now, you know by now is that in apoptosis, there is no inflammatory reaction. But in necrosis, due to the leak of this intracellular component, there is local inflammatory reaction. There are different types of necrosis that you need to know. But if you don't want to remember anything, I would suggest you to at least remember the name, where this name of the organs, where this sort of necrosis, where this type of necrosis occur. So whenever if someone asks you, coagulative necrosis occurs in, then you need to say that it occurs in most of the tissues except brain. And liquefaction necrosis occurs in brain. This liquefaction necrosis is very, very important, and is almost always asked in even your self-examinations, or many, many times asked in the USMLE examinations too. So the coagulative necrosis is seen in ischemia infarcts in most tissues. For example, so this is the coagulative necrosis, the histology type. So what we can see is that there is increased cytoplasmic binding of eosin. Okay, so there is increased red or pink color. In case of neutral liquefaction necrosis, there are cystic spaces and cavitation in the CNS. Here we can see. In case of caseous necrosis, which typically occurs in a systemic fungi or tuberculosis infection, which gives a cheese-like appearance. Here you can see this is the cheese-like appearance. Fat necrosis is when there is enzymatic activation, for example, in case of acute pancreatitis, which causes the saponification of the fat. We can see saponification of fat, which appears as the dark blue on H&E stain. This dark blue areas is the saponification of fat, and this is fat necrosis. Now, talking about fibroid necrosis, which is typically in the immune vascular reactions, for example, polyarteritis nodosa, and the vessel walls contains eosinophilic layer of proteinaceous material. Here we can see this is the vessel wall, and here we can see these are the eosinophilic, these are the eosinophilic proteinaceous material. Gangrenous necrosis obviously can be seen in these fingertips, causing gangrene and ultimately sloughing of the parts. So 45-year-old woman presents to her primary care physician with complaints of irregular menstrual cycles and pelvic pain. She has a past medical history significant for obesity and hypertension. Physical examination reveals an enlarged uterus. Ultrasound imaging confirms the presence of multiple uterine fibroids. Which of the following cellular adaptations is most likely responsible for the enlargement of the uterus in this patient? Metaplasia, hyperplasia, atrophy, or dysplasia? So the answer here is hyperplasia. You can pause the video and go through the explanations. So 68-year-old male presents to his primary care physician with complaints of weakness and difficulty walking. He reports a significant decline in his physical activity over the past few months. His past medical history is notable for chronic obstructive pulmonary disease and congestive heart failure. On physical examination, there is muscle wasting. And which of the following cellular processes is most likely responsible for the observed muscle wasting? The answer is atrophy. Thank you for watching. Keep studying.